you all to participate in our upcoming ASAMI at Chandigarh. Now I request Dr. Rajiv Kaul to take over and start.
Thank you, sir. So, good evening to all our viewers from India and overseas. At the outset, I welcome you all to today's webinar, which is on the basics of Ilizarov, and we represent the Uttar Pradesh and Uttarakhand chapter. We'll be covering some basic topics related to the Tibia and Ilizarov application on the Tibia. We have with us today an elite panel of specialists, masters in the field, beginning with none other than our President of ASAMI India, Dr. Rajat Agrawal. And we also have some senior faculty of ASAMI. We have Dr. Mohit from AIIMS Hrishikesh and Dr. Gaurav Sanjay joining us tonight. I'd like to introduce our faculty. He needs no introduction. He's the President of ASAMI India, Dr. Rajat Agrawal. He's a gold medalist in MBBS and an MS Ortho from Himalayan Institute, Dehradun. He has held the post of Secretary ASAMI India, also Vice President, and finally became the President in 2023. He has a number of fellowships to his name, including those in deformity correction from Bombay, from Baltimore Institute, and from Kurgan, in addition to a spine and an arthroplasty fellowship from India and abroad. In 2009, he joined the Government Medical College, Gorakhpur, as an assistant professor, and thereafter he took over as the CEO of his current institution, which is Agrawal Orthopaedic Hospital and Research Institute in Gorakhpur, Uttar Pradesh. Every year he runs a number of fellowship programs. I myself have been fortunate enough to have visited him and imbibed some of those amazing skills. And his institution also runs the famous Gorakhpur Deformity course. So welcome, Dr. Rajat sir, to this webinar.
Thank you.
Next up, we have an esteemed faculty of ASAMI India. He is Professor Mohit Dhingra from AIIMS Rishikesh. He is a graduate of Lokmanya Tilak Medical College, Sion, Mumbai, and he did his MS Ortho from KGMC Lucknow. He has more than 40 papers to his credit, all in indexed international and national journals. He has contributed 5 book chapters published by Springer. He has presented numerous papers both as a faculty and as a speaker at national and international forums. And he's worked exclusively in musculoskeletal oncology and reconstructive surgeries, including Ilizarov and limb reconstruction. So welcome, Dr. Mohit sir, to this webinar, and we hope to gain a lot from you.
Thank you. Thank you very much.
It gives me great pleasure in introducing Dr. Gaurav Sanjay from Himalayan Institute, Uttarakhand, India. Dr. Gaurav is, in addition to all his orthopedic degrees, he also holds an MBA in hospital management, and he has numerous fellowships in spine, arthroplasty, Ilizarov, and trauma from every part of the globe that you can think of. Presently, he works as a consultant at his own private hospital, which is Sanjay Orthopaedic and Maternity Hospital in Dehradun. He holds the coveted position of Secretary, Dehradun Orthopaedic Society. He is an active member of CCOT and other organizations, including the Indian Medical Academy. He has multiple publications in international and national journals and has more than 50 presentations in state and national as well as international conferences. So welcome, Dr. Gaurav sir, to this webinar.
Thank you, Dr. Rajiv.
And finally, I'd like to remind you all, please register for the upcoming national conference, which is ASAMICon 2025. It's at Chandigarh. It's going to be held from the 6th to 9th of February next month. So kindly register now and make the most of this wonderful event. With that, I'd like to invite Dr. Rajat sir for his talk, which is step-by-step application of Ilizarov in Tibia.
Okay, thank you, Rajiv. And I will be presenting my talk on the step-by-step Ilizarov frame application. You must understand that I'm an orthopedic surgeon from a Tier B city, Gorakhpur, and like thousands of orthopedic surgeons in India, we have to do almost every cases, except few surgeons in the metros. Very few has the luxury to operate only on a particular type of cases or do a particular type of technique. So an orthopedic surgeon. I do Ilizarov, I do joints, I do spine. So as my main purpose as the president of ASAMI India was to ignite among the orthopedic surgeons a desire to do Ilizarov surgery and give some basic presentations on basic tips how to do Ilizarov on one of the most common cases, that is the compound fractures tibia. My only appeal is that we don't want you to become only Ilizarov surgeons. If among all types of surgeries you are doing, especially in cases of compound fractures tibia, if you can primarily do Ilizarov, a lot of things can be saved for the surgeon as well as for the patient. Like these type of cases, if you don't do Ilizarov, you'll be doing a temporary X-fix and then maybe later plating or a nailing, and many times it gets infected. Like this is a very common scenario which comes in our OPD practice. Somebody did a primary nailing in a combined fractured tibia. It went into infected non-union. So we removed the plate, we did a corticotomy, thorough debridement. We were able to finally achieve union. But it's always the question comes in my mind, why the surgeon didn't did Ilizarov only at the first place? So many times, like this was a case, you can do just one surgery and you can manage everything and there's no implant inside. So the chances of infection will be less and patient can be saved a lot. So in this field, I'm presenting this talk to make the things easy, especially for the beginners, how to apply Ilizarov in a case of fractures in tibia. So we talk about the parts of an Ilizarov frame. Basically, there are two components. One is the frame, which is made by rings and threaded rods. And second, the transosseous elements, the K-wires and the pins by which we fix the frame to the bone. So first, we do a preoperative making of a pre-assembled frame in which we make the rings and connect them with the rods. And second, in the operation theater, we fix this frame to the bone with help of wires and the pins. So first, the making of the pre-assembled frame, the rings and the rods. How to make a pre-assembled frame? Step one is you have to select the right size of the ring. So the distance between the bone and the ring, the lesser is the distance, the stronger will be the fixation. So there are two options actually. One, depending on the girth of the leg, you can take different ring sizes. There will be a minimum distance from the soft tissue, which will cause increase in the strength of the fixator, but it has to be connected by a plates, which will decrease the strength of the fixator. And if you take a same ring size, it is easier to assemble, but at some parts, there is an increased distance from the bone, which may cause a little decrease in the strength. So what you should do, you should have the same ring size of all the rings. If the difference between the upper and lower leg, the girth, is less than 5 to 6 centimeters. But if it is more than 5 to 6 centimeters, you can take two different ring sizes. Second, you have to decide on the number of the rings. If the bone fragment on one side is up to 10 centimeters, you can go with one ring in that segment. Or if it's more than 10 centimeters, then you should go for two rings. Third, you have to decide the size of the frame. So on the X-ray, you can have a clear idea about the size of the frame. The level of the rings, the first ring should be at the level of the head of the fibula. And the last ring is 2 to 5 centimeters from the ankle joint. And the middle two ring should roughly be 1 hand breadth from each other with fracture in the middle. Something like this, if there is a fracture in the middle, then there will be 4 rings, 2 above and 2 below. Then how to make full rings? Because when you get the instruments and the implants, you get half rings. So the both half rings are connected with the bolts to make a full ring. And you must be aware to see the positions of this full ring, because it has to be connected in that particular manner. You can't connect the ring in an opposite manner. One person holds the rings and another person tightens the bolt and the nut. So there are two half rings, a bolt and a nut. And with two bolts and two nuts, you make a full ring out of two half rings. Then when you make 3 or 4 rings, depending on the number of rings you're planning to apply, the two rods are used to fix the frame. Put rods usually on the first hole on the side of the center bolt, and both rods should be in the opposite holes. Like if one above is on the lateral side, then the one below rod will be on the medial side on the first hole. Now keep the rods flush on the outer side. And on the inner side, you can keep a rod longer 1 to 2 finger breadths to increase the length of the frame if it's needed later on during the post-op period. Rod length should be same on the both sides, and it can be measured on the sides either between the rings or the portion which is protruding out if you have used the same size rods on both the sides. Now you have to decide on the number of the threaded rods. Usually more the rods, more rigid is the frame. There should be roughly a uniform distribution of the connecting rods. They should be placed as far as possible from each other. If you are applying 2 full rings, 3 rods is sufficient, but usually we go up to 4. Usually, personally, I apply 4 rods. If the ring is not full, then you should apply 4 rods. Now, as I will be explaining the technique, usually the rings are called the basic rings and the reduction rings. Basic ring is usually one which is at the proximal tibia and the distal tibia, the blue color. And the reduction rings are the rings which are in the middle, which are in the red color, that are called reduction rings. Now, as we talked about the rings and the rods, now we come to the second part of the Ilizarov frame, that is the wires and the pins. So, the wires can be of different diameters. Usually what we use in Ilizarov in adults is 1.8 millimeters, and in children's forearm and foot, 1.5 millimeters. The pins can be 4, 5 or 6 mm. Usually most commonly we use 6 millimeter pins tapered to 5 millimeter because it does not loosen. Now wires can be bayonet type or trocar types. A bayonet type 1.5 mm is used in the diaphyseal of the forearm and the foot bones, and the bayonet type 1.8 mm is used in the diaphysis of the tibia and the femur. Then the second is the trocar point. It is used in the metaphyseal of the forearm. If it's 1.8 mm, it is used in the metaepiphyseal region of the tibia and the femur. So we have bayonet tip and the trocar tip. The pins can be 4, 5 or 6 mm, and accordingly we have different drill sizes, 2.7, 3.8 and 4.8 mm drill. Now, the wires has to be fixed to the ring by a slotted wire fixation bolt. So when the wire comes on the one side of the hole, you fix it with a slotted wire fixation bolt. Now you must understand that the skin, when you pierce the wire in the skin, the rotation part, because that's the most dangerous part because the neurovascular signatures can get tangled in it. So you do the rotation just at the point when you are piercing the skin. Only at that time, usually the rotation is needed. Once you are inside the skin in the muscular part, you can just push the wire to the bone. Then the chances of the neurovascular injury will be minimal. And as you touch the bone and feel the bone firmly, then you can start the rotation component. You can pass the wires in different directions. Only thing that the wire, some part should be inside the medullary cavity. Not like this when the whole wire is passing only to the cortex. This causes a lot of thermal necrosis and the chances of an infection osteomyelitis can be higher. Now when you pass the wire through the bone, the maximum rotation which is allowed is 850 revolutions per minute. As you reach, when you start, you do a rotation, you comes into the medullary cavity and you stop as you reach the other side of the cortex. Then you wait for 5-10 seconds because a lot of heat is generated. Then you again rotate and you pierce the second cortex. As you pierce the second cortex, you again stop the rotation, and then you can take out the wire either with small rotations or better with a hammer. So outside the second cortex, you can only use a hammer to take out the wire or very small rotations. To avoid the joint stiffness, as you are passing the wire, at whatever side you are passing the wire, that side joint should be stretched. So when you're passing on the ankle and you're putting a wire, first you plantar flex and then you dorsiflex. Now, usually if the angles between the wires are between 30 to 60 degrees is pretty fine. Two wires passing with an angle less than 30 degrees will cause decrease in the stability of the frame. And because of the neurovascular structures, it many times is difficult to make an angle more than 60 degrees. So if your wires are passing between 30 and 60 degrees, it's a good frame. Next, many times you pass the wires and there occurs a tensioning of the skin. So you always cut with a 15 number blade and make one stitch. There's no harm in that. The soft tissue structures will be better. When you push the wire, many times initially you will see that you are bending the wire because of the excess pressure. So while putting the wire, just see that your wires are not bending and have a uniform pressure. Now, many times, even with experts, when you pass the wires parallel to the ring, you try to put the wire in flush with the ring. But as the wire goes on the other side, many times there's a distance between the wire and the ring. There's no problem in that. Instead of taking the wire out and trying to get a perfect location and drilling the bone with the wire multiple times, it's better you just fix the wire with a post or a washer to the ring, but never try to bend the wire to make it close to the ring. These are very small tips, but it's very important if you want to apply a good fixator. So never try to push the wire to get it flush with the ring. Just take a male post or a washer and fix the wire to the ring. Now the cutting of the wire, because wire tips are very sharp, as soon as you put the wire, you cut the sharp tip of it and usually cut a 3-finger breadth for future use. Now bend the wire to hide the tip in the ring, because in the post-op period, the wire tip may injure the patient or the compounders or the nurses who are doing the surgery or doing the dressings. So it's better you bend the wire and you hide the tip under the ring and have a smooth bend, because if later on you have to give some tension or use the wire, then you need to have a smooth bend. And bend inside of the ring, opposite the wire fixation bolt, to avoid the injury during the dressing. Now, I will be explaining the frame. Like we had rings, two types, the reduction rings and the basic rings. We call wires also three types of wires. One we call as the reference wire, which are close to the joints and parallel to the joints. And second, the reduction wires, which are close to the fracture, by which we try to reduce the fracture. And third are the stabilizing wires. When you have added the reference and the reduction wires, you add the wires for additional strength of the frame. So as far as possible, from the reduction wires in between the reference and the reduction wires. So these are the three types of terminology for wires: reference wire, reduction wire, and stabilizing wires. Now, difference between the reference and the reduction wires. Greater the distance between the wires, greater the bone span, and greater the strength. So reference wires should be as close to the joint, and reduction wires should be as close to the fractures, few millimeters from the fracture line, few centimeters. Now, this was some basic tips regarding the rings and the bolts, rods, and the wires. Now, let's start with the operative technique. So I will take a simple fracture. There was a badly comminuted tibia fracture with a puncture wound. So instead of applying a plate, we decided to put an Ilizarov frame over that in a 65 years old male. So these are the small steps we follow whenever we try to apply an Ilizarov frame. So I will be explaining every step in detail. So the step one is the leg position. This is usually the leg position we keep in our operation theatre. We have made two supports made of the Ilizarov components, a thigh support and a heel support. This gives a very good 360-degree working space for us, and we can apply the frame easily. Or if you want to need a skeletal traction, you can apply a skeletal traction, because with traction, almost 50% of the displacement gets corrected by itself. So, or you can apply a traction with a fracture table. So either you put two stands, you apply a fracture table with a wire in the calcaneus, or you just apply the foot support. So the first wire we apply is what is called as a proximal tibia reference wires. Reference wires are the initial wires which decide the configuration of the frame. So first we apply the proximal tibia. It will decide the varus and valgus of the frame. If you don't apply it parallel to the joint line, it may lead to varus or valgus deformity. The distance of wire from the joint line, usually it is applied at the level of the head of the fibula. It must be parallel to the joint line, so you need a C-arm. This is one of the wires you have to apply under a C-arm. And it has to be parallel to the joint, and it has to be parallel to the ground. Parallel to the ground means when you apply the wire, you see the ground as you try to see that the wire is almost going parallel to the ground. And it has to be perpendicular to the axis of the bony fragment. Suppose you have some deformity, you don't have to then apply the wire just parallel. You have the wire should be perpendicular to the axis of the bony fragment. And roughly it should be middle in between the anterior and the posterior cortex as you apply the wire. So this is the proximal tibia reference wire we apply under the C-arm guidance. So we have just put a frame inside, but first we apply the wire. So this is at the head of the tip of the head of the fibula. We put the wire, I check on the C-arm, I check that it's going parallel to the joint line. Again, I check that it's going parallel to the joint line. These are one of the few instances when you need a C-arm. So I applied this wire on the C-arm, getting sure that's parallel to the joint line. And this is the cut section. This is the wire with number 9 to 3. That's the proximal tibia reference wire, a parallel wire, 9 to 3. Then you have applied a proximal tibia reference wire. Then on this wire, you fix the frame. Frame you have made during the preoperative period. So for this, you have to finalize the distance of the ring above and below the skin. Usually 2 finger breadth above is there kept as a distance, and all other space is left for below the calf, because as the swelling will increase, there will be a decrease, calf will increase, and the distance between the calf and the lower ring will decrease. You just have a 2 finger breadth above and keep all space left for the posterior part. Check rotation of the frame, for which the central bolt of the ring should be on the shin of the tibia. And fix the frame with 2 bolts and wire fixation bolts and nuts to the proximal reference wire. When you fix the frame, you check distance of the frame also on the medial and the lateral side, that it's almost the distance is equal. It's not, many times you will see that the distance on medial side is less, lateral side is more. So when you fix it with a hammer, you can adjust it, and you can see that the distance on the medial and lateral side is almost similar. So again, 2 finger breadth above for rotation, bolt on the shin of the tibia, and medial lateral distance should be the same. So this was the proximal tibia reference wire, and we fixed the frame proximally with this wire. Now adjust the length of the frame distally after giving traction. If you need a traction, which is needed on both sides. If you have applied a fractional travel, you have already given a traction. If you have used this supports, then you have to give ask an assistant to apply the traction manually. traction will restore the length. And if you have not applied a fracture table, then sometimes the calf, there's a posterior sagging of the fracture. So you can just put a hand on your calf and elevate the fracture to avoid the posterior sagging, and an assistant can give a manual traction. Because at this stage, the traction is needed to restore the length. So as in this case, we applied a fracture table, so traction was already given. Now, distally, you have to fix the frame to the via the distal reference wire. So there was one wire proximally, and now you have to apply one wire distally to make a basic full configuration. Now this distal tibia wire will decide the procurvatum and the recurvatum deformity. This wire should also be parallel to the joint in flush with the ring, and for this wire also you need a C-arm. You can't rely on the frame that you can just pass the wire in flush with the frame, because there may be a deformity at the fracture side, so it may not be parallel to the ankle joint. Now make the frame parallel to the fibula, because there is a lot of swelling in the leg region during this fracture time. So imagine the fibula and try to make the frame parallel to the fibula with a 2-finger breadth anteriorly between the ring and the skin. Adjust you see from the side and adjust the distance of the frame above and below the leg. Try to imagine it parallel to the fibula, and then you apply the distal reference wire. Now your assistant holds the frame in the position you desire to keep it, and you apply a distal reference wire. So somebody is holding the frame and you are applying a distal tibia reference wire. Now, because I used a foot support in the fracture table, so I couldn't put the wire in the distally, but my wire is parallel to the ankle joint. I checked it on the C-arm and I applied the wire. So you will be having a frame fixed with one proximal tibia reference wire and one distal tibia reference wire, and the ring should be perpendicular to the bone in both the planes in AP and the lateral view. So you should check with the C-arm that their rings are perpendicular to the bone. So now this is the basic, your basic frame is ready now. You have just applied 2 wires, one proximally and one distally, and applied a pre-assembled frame, and your basic work is almost 80% done. Now at this position, you have to check the position of the middle ring, whether it's below the fracture, because you have to apply wires in that. Because sometimes in the pre-op, the distance between the ring may not be that accurate. So if at this position, you see that the ring is not at the exact side where you want it to be, with the threaded rods, you can always change the position of the ring. That's why I've told earlier that the rods on the inner side should be kept a little longer to have this easy manipulation during the surgery. Now, whenever you put the wire, at the same time, you should tension it. So there are many ways of tensioning the wire. The most common, which we recommend, you have to have a dynamic tensionometer. Usually it comes a little costly, but this is one thing you should have in your operation theatre, because a proper tensioning is very, very important for a successful frame and a successful surgery. So with a dynamic tensionometer, usually 90 to 110 amount, you apply the tension. There are manual tensionometers also, which are comparatively very cheap, but there is no marking. So you can't have an accurate assessment how much tensioning you are given. After applying a manual tensionometer, you can tap the wire with a spanner to feel and hear the tension. This is a rough thing, but if you don't have a dynamic tensionometer, you can go for a manual tensionometer. For the manual tensionometer, the nut of the wire fixation bolt should be at the center of the wire temp. When you apply a wire temperature, as you can see the figure on the left side, the nut should be in the center of the wire tensioner bolt, because you have to apply a wrench to do the tensioning. If you have your nut is on one side of the tensionometer, you will not be able to apply your wrench and you have to reapply again. Now there is a third technique. We don't have any tensionometer, manual or dynamic. You can do tensioning. You can just use wrenches, and with holding one wrench on one side, you can manually rotate the wire and give a tensioning. So if you don't have a tensionometer, your tensionometer is damaged, by this manual rotation, you can always also give tension to the wire. Now, insufficient wire tension reduces the strength. In a closed ring, it's usually 90 to 110 kgs. In open ring, it should be 50 to 70 kgs. Above this tension, there's plastic deformation of the wire instead of the elasticity. So it's better to use a dynamic tensionometer in your OT, and if possible, avoid manual one. Now comes the step 6. So you have applied a frame, you have give tensioning. Now many times the fracture fragments are close to each other, so you will not able to reduce them. So it's better to have a distraction of 3 to 5 millimeter between the fracture fragments so they can easily be reduced. So it avoids shifting of the fracture ends, and it may lead to further comminution while you're trying to do the reduction. So it's always better to have a little gap. So you do a distraction with the threaded rods. Now comes the step 7. You have to reduce the fracture, because most of the times we are not opening the fracture. You have to reduce them. So to reduce them, the distance, you have to apply the reduction wires. The distance between the reference and reduction wires, more the distance, more strong fixation. So you have applied the reference wires near the joint. For reduction wires, you apply it close to the fracture, 1 to 3 centimeter from the fracture line, perpendicular to the bone, and you try to reduce the fracture. Reduction can be done in 2 ways. First, you move the pins and the wires. Rings don't move. This is usually we do in the fractures. And second option is you move the rings by hinges. This is usually done in cases of deformity correction. So in case of fractures, you just move the pins and the wires to reduce the fracture. For example, if there is a medial or lateral displacement in the coronal plane, you put an olive wire on one side and you tension on the opposite. The fragment will be pulled towards the center. So you are moving the wire. The ring remains in its position. If there is a posterior sag, the fracture is displaced posteriorly. You fix the wires with one hole anterior, means the hole where the wire is usually coming. You don't fix the wire in that hole. You fix the wire with one hole above. So as you will tension it, the fragment will be pulled anteriorly and you will be able to reduce the posterior displacement in the sagittal plane. Many times if there's angulation, you can put an olive wire, you pull it, you can reduce the fracture. There are many ways, many small technique with the wires and the olives, you can try to reduce. In this fracture, there was a fragment which was a little displaced, so I put an olive wire and I pulled it. So these are the reduction wires. I put an olive wire here and I fixed it. You have to put a 15 number blade, a small nick, so that the ball of the olive wire can go inside the skin. Now there are many ways to reduce the wire. One is this with the wires. Suppose it's a compound fracture and it's already open. So you can just put a temporary plate to reduce the fragment, and you put a frame and then you remove the plate. If the fracture is already open, suppose this type of case comes to you, you apply a temporary plate to fix it properly. You put a frame and you take out the plate. Like this was the post-op X-ray. Initially, it was fixed with plate during the surgery. Later on, we removed the plate and just keep the lab screws inside that. Similarly, a boy with a fracture, we reduced it with a small plate. We applied the frame. It's always that if it's an open fracture, the quality of reduction you can get with a plate, obviously you can't do it when you are not doing directly. So we applied the plate, applied the frame, and later on we just remove the plate and close the wound. So these are the many different types of reduction. You can apply whatever you want to. Now comes the next step of stabilizing pins. So initially you applied the reference wires to fix the frame. Then you applied the reduction wires to reduce the fracture. And now comes the last third type of wires, the stabilizing wire. These are just the wires to add an extra strength. Usually when you apply all these wires, the frames looks complicated to a beginner, that it looks very complicated. But actually it's only the reference wires which fix the frame and the reduction wires. These are just, you are adding the wires. There's nothing great in that. There's no technology in that as such. So how many wires to add to stabilize to increase the strength? Greater the number, the strength will be greater. But greater the number, there will be more soft tissue trauma and joint stiffness. So there has to be a balance. So usually 3 wires of pin in a ring, including a drop wire, is quite sufficient. So usually we apply 3 wires of pins. In the proximal ring, usually we apply 2 wires flush with ring and 1 drop wire. Or in many cases of deformity, we apply 1 wire only, the reference wire, and 2 pins. Distally, you can apply 2 wires and 1 drop wire, or 1 wire to fix the ring and then 2 pins instead of the wires. In the middle, many surgeons avoid putting the wires, especially in the young patient, because a lot of thermal necrosis occurs. So some put 2 wires and 1 with the ring and 1 drop wire if you want to put only the wires. Or many times the surgeon avoids the wires and just put 2 or 3 pins. It depends on the surgeon and depend on the bone quality. If it's a very hard bone, a young patient, then pins may be better instead of the wires. Now, in the proximal tibia, you have applied 1 reference wire till now in the proximal tibia. Now you have to just add on wires. Second wire you can pass to the head of the fibula if you want to fix the proximal tibiofibular joint from posterolateral to anteromedial direction. But you have to see that the lateral popliteal nerve passes behind the head of the fibula. So you have to be careful regarding that. Many times in case of acute fractures, there's a lot of swelling. So you may not be able to palpate properly the head of the fibula. So many times, if you want to avoid it, it's okay. If you want to pass it, you can do that. So the figure number 2 and 8, this wire, if you are applying from the lateral side, it goes from the head of the fibula to the tibia. 9-3 is your proximal tibia reference wire, which was the first wire you inserted. And other wires can be from 10 to 4, or 9 to 3 was a reference, or from 8 to 2. Usually these are the positions you apply the 3 proximal wires. So the third wire, I add a stabilization wire put on the side opposite. If you have put the reference wire outside the ring, the second wire should be inside the ring, because the wire should be on both sides of the rings. Now you applied this stabilization wire, the second wire, and most of the times I prefer a drop wire. What is a drop wire? It increases stability. You put the wire 1 to 2 male post away from the ring. You don't put the wire in flush with the ring. You put a gap of 1 to 2 hole male post. And in that, you can't tension the wire with a tensionometer. There are things called hexagonal socket. With the help of them, you can tension these wires. And since these wires are not in flush with the rings, you don't have to give the 110 or 130 kg tension. You have to give only 50 to 70 kg tension. Otherwise, the post which with you have fixed the wire to the ring, they will start bending to each other. So this is a drop wire in the So now in the proximal tibia, there are 3 wires. First was the reference wire, then the second stabilization wire, and the third drop wire. Distally, we had put a 1 distal tibia reference wire. So second wire we pass usually through the fibula from posterolateral to the anteromedial position. For that, you first palpate the fibula where you want to put the wire. So this is the cut section from fibula to tibia. you can pass this second stabilization wire. Now, with the tip of the wire, you feel the fibula. This is the point where you want to put the wire. And usually you sit, because you can't put this wire while standing. So you sit on a stool and then you put this wire. So this is the stabilization wire from the fibula to the tibia. And then we apply the third stabilization wire. Usually I put the drop wire. So 3 wires in the distal tibia. So these are the 3 wires in the distal tibia. Now middle ring is left. So since this was a 65 years old male, the bone quality was not that hard. So I preferred using a wire. Usually it depends on the surgeon to surgeon, but my preference is the wires, because with the wires, when the patient goes for the weight bearing, there is a little micro movement at the fracture sites, which helps in better healing. With the pins, the frames are a little more rigid, so the chances of micro motion is less. But mainly the deciding factor will be the age of the patient. So in this case, I put 2 wires flush with the ring and 1 drop wire. So this is a section for the upper tibia. You can have section 9 to 3 in that direction. You can have 10 to 4 in that direction. Usually these are the most common wire directions because the neurovascular structures are below. So 9 to 3 and 10 to 4. These are the preferred. If you want to apply the pin, you can apply in number 12, number 1, number 2, number 3. So these 4 sides are usually for the pins, and 10 to 4 and 9 to 3 are for the wires. For the lower level, again, you can apply the wire 10 to 4 direction or 9 to 3 direction. These are the safe zones. And you are applying a pin, then it will be 12, 1, 2, 3. On the medial side, you can apply the pins. So these are with this figures in mind, you can easily put the wires. So this is the first stabilization wire I put in the middle ring. And I check on the C-arm that it's a little near to the fracture, not going through the fracture. Then I put a drop wire a little away and I will fix it with a male post. And then I applied the third wire, second stabilization wire in the middle ring. So finally, in the middle, I put a 3 wires in the middle, 3 wires in the proximal tibia, and 3 wires in the distal tibia. So it's a total 9 wires configuration with 3 full rings. Now the last thing is you have fixed the frame, you have reduced the fractures, and now you compress it because earlier you did a little distraction to facilitate the wire or the fracture reduction. So with the threaded rods, you compress the fracture and you check on the CR for a proper final reduction. Now the last step is, because earlier when we have applied the frame preoperatively, we had applied just 2 threaded rods. At that time, we don't apply 4 rods because it will hinder to see the fracture site. So now when the frame is fixed, or when you have to tension the wire, before that you can add. Usually we apply 4 rods between 2 rings. You can have 3 or 4, but my personal preference is 4 rods between 2 full rings. Now the last, because this is the point where most of the surgeons, they get tired and they don't do it. You have applied the frame, but you have to check because you're not tightening the frame individually. You have your 2-3 assistants with you. And someone may have not tightened properly the nuts and the bolts. So you have to check for every joint that it is properly tightened or not. Because it's a loose frame, as soon as the patient will start weight bearing, he will be having pain. So first you made the rings. So you check in this serial order, you check the bolts with which you tighten the rings. So it has 3 rings, so it will be having 6 bolts, 3 above and 3 below on the 3 rings. Now after that, you checked all the wire fixation bolts and nuts. I applied 9 wires. So there will be 18 wire fixation bolts in total. you've checked those 18 wire fixation bolts. Then you checked rods and the nuts, whether they are properly tightened or not. This will be having 8 rods. So there will be 16 rod nuts combination, which you have to check. And finally, you see that none of your wires are bent. If they are bent, you can always straighten it. So around 40-50 joints are there, but you have to check it for a proper stable frame. So you check it with the 2 wrenches. You quickly check everything that your frame is properly tightened, and you can finish the surgery. So this was the final frame. Fracture in the upper half of the tibia. So we had 3 rings and 9 wires. Well, it's a very simple configuration as such. So this was the post-op X-ray. So this was pre-op and the final in the AP view. This is case of final is in April 2024, around 9 months, 8 to 9 months before. I tried to get for the recent X-rays, but the patient is not coming. So, and many times with the Ilizarov, if your patient is not coming, it means the surgery was done in a good manner. Because if there will be any complaint, the patient will come. This is the lateral view, the pre-op and the final. Thank you very much. So I think these are some of the very basic tips, something close to my heart. My only appeal is to have some ignition inside yourself to apply Ilizarov where it is better than the other modalities for treatment, especially in the tibia fractures. And I am hopeful that with this basic videos, which we'll be putting in the YouTube of ASAMI India, you will gain some confidence in starting to do tibia fractures. And I invite you to our annual conference, the biggest event annually held in India regarding Ilizarov and deformities. It will be between 6th to 9th Feb in Chandigarh. So we hope to see you there, and let's ignite the fire and do Ilizarov and other deformity modalities, learn them. Thanks a lot. Thank you.
Thank you so much, Dr. Rajat sir, for that comprehensive talk and for simplifying such a vast topic. In fact, I think in a nutshell, you covered the entire ASAMI manual in a short span of 30 to 40 minutes. So thank you so much. I'm sure our viewers and especially the budding limb reconstructive surgeons must have definitely benefited from this summary that you've given. And if there are any questions for Dr. Rajat sir, we can take them now, or else you can drop them in the chat box and we'll answer subsequently.
Rajat, there is a controversy all over the world. Hybrid fixator and only they use the K-wires. So what do you think? What do you think? What is better?
Sir, as I told in my talk, that depends on the age of the patient. My personal preference will be all wires because with this what I feel we get a better micro motion at the fracture site. But if it's a hard bone, so I will be avoiding wires, especially in the diaphyseal region, and I will be going with the pins with a hybrid fixator. And if it's a little older patient where the bones are not that strong and wire can go easily, then I will prefer an all wire configuration.
But actually, we have found that sometimes the bone unites when you do the compression at the fracture site. So by half rings, pins, sometimes it is not possible to give the compression. So initially I was using the half pin hybrid fixator, but then I found that certain patients had gone to the non-union. So we thought it's a better because the bone unites when you do the compression. So the wires become like bow. So then I thought it's better to use the wires instead of half pin hybrid fixator.
Yes, sir.
Thank you, Dr. R.A. sir, for those pearls of wisdom. Thank you so much. With that, I'd like to now invite our next speaker, Dr. Mohit sir. May I invite you to come and share your screen and deliver your talk on Ilizarov preoperative planning. Sir.
It's no.
Thank you, Dr. Rajiv. I think most of the things have been covered by Dr. Rajat. I mean, he elaborated it very well. Let me see if I can do something different. Is my screen visible?
Yes, sir, it is.
Okay. Now, coming to the pre-op planning, I think Dr. Rajat has talked very well. I mean, he has elaborated about the making of frame and where to use pins, where to use wires, when to use pins and when to use wires. Uh, okay, but since I have to give a talk, so I would like to cover my topic on these few headings in which I am going to tell about where the Ilizarov has to be used in case of fresh open fractures of tibia, what you need to clinically evaluate before going in for fixation with Ilizarov, what are the imaging techniques you should use for assessment of these patients, what is the right frame, what is the right osseous elements like wire and pins to be used, what are the bony and soft tissue consideration what you have to take into account when you are doing the surgeries. Also, you have to what you have to follow for pain control and educating the patients and rehabilitation and conclusion with some case studies. So this magic instrument has been given by Ilizarov in 1950, where he used to do fractures, non-union, deformities, lengthening, all these things. And it is rightly said that this apparatus is actually a biomechanical stabilizer. That means it has biological as well as mechanical properties. And I think if this is I feel this is the last option to salvage a limb, because if you can't salvage a limb with Ilizarov, I think the patient has to undergo amputation. Okay, so why preoperative planning? Because Ilizarov is a long surgery, and if you plan your surgery well, I think you can save a lot of time on table, and you can and when you save time, actually you can enhance your precision and reduce the complications of malalignment in your cases. So when do you use it? So most of the common indications, because if you have a fractured tibia coming to your emergency, I think most of the people will go for nailing, because that's the simplest and a easier method to operate a case of tibia. But as Dr. Rajat also pointed out rightly, that when you have a comminuted fracture of a diphyseal comminuted fracture, I think rather than going for a fixation with a nail, Ilizarov is a better option, because first of all, the chance of infections are reduced. Secondly, you can maintain the length very well. And also, if this case goes into a kind of this fragment goes into non-union, you can just add a ring in between and do a corticotomy and shift this bone above or below. So the further surgery would be easier surgery if you choose Ilizarov in these cases. Also, Ilizarov is being used for fractures which are very near to the joints, periarticular fractures. There, Ilizarov has a very good role, because soft tissue compromise occurs very commonly in case of proximal tibial fractures. And many people must have seen that proximal tibial fractures are associated with a lot of swelling or compartment syndrome. So when you are using Ilizarov, I think you can maintain the length of the bone very well and manage the fragments easily. Okay, next thing to evaluate is the fracture grading, and you have to evaluate the soft tissue defect. Also, the mentation of the patient is very important, because this is not a nail which you just put inside and you send this patient home and the patient just see the scars. The patient should be mentally ready to keep this Ilizarov for a long time, because this frame has a lot of social implications as well, and he has to manage his uh, personal activities, and he has to modify his personal activities with the presence of this frame. Also, the local conditions like smoke, if the patient is smoker, he can have problems of soft tissue problems, or he can have some problems of union as well. Soft tissues actually for me is the workhorse of all the of tibial fractures, because if we don't respect the soft tissue, I think our tibial fracture is going to non-union. So we should always have first address the soft tissue in case of open tibia fractures. And when we talk about soft tissue, I think most of the times we first go for some stabilizing fixation and cover this defect with a graft or a flap, and then secondarily we go for bony procedures, or we can go for the bony procedures simultaneously along with this fractures. There are various flaps available. You can do some rotation flaps, or you can rotate the medial gastrocnemius over the proximal tibia, or you can do some proper flaps in the mid part of the leg, cover the tibial defect properly, and then go for a final fixation with Ilizarov. Coming on to imaging, I think we need to have a full length X-ray of the limb. We need to involve the proximal joint as well as the distal joint. We need to see what is the amount of comminution present. We need to see what is the alignment of our proximal and distal part, what is the location of the fracture, and what is the bone quality. Because when we see the bone quality in the osteoporotic bone, we have to use wires instead of pins, and in a bone of a young patient, we mostly go for a pin fixation in the middle part of the leg, that is the diaphyseal part of the leg. CT scan is used in few cases where we have a doubt of fracture going to the joint. Otherwise, most of the time, CT scan is not required for a diaphyseal fractures. As Dr. Rajat also said that all these frames, they come into different sizes, and they normally come in 1/2 sizes. These 1/2 are joined together to make a full ring. Uh, there are also 5/8 rings available, which are mostly used near the joint to allow the movement of the joint freely, that is the knee joint. Also, these 5/8 rings can be used in the middle part of the leg if we are planning some soft tissue procedures in the leg along with the Ilizarov fixation. So these rings can be used in between along with the soft tissue procedures if you have to do. Now we have to identify what levels we have to put the rings. So whenever we are spanning the whole tibia, we have to have the rings, first ring at the level of the head of the fibula, the last ring at the level of the joint, and the rest of the rings we decide according to the type of the fracture present. So, so our aim is to actually achieve an anatomical, functional, and a physiological injured limb. So we have to basically do all these exercises in order to achieve the anatomical reduction of these fractures, and then we have to achieve the good functional status of the limb and also the physiology of the injured limb. So how do we do that? So each fragment, if we have a case of a gap non-union, then we treat the longer fragment, and we are doing an osteotomy, then we treat this longer fragment as two fragments. So each fragment should have at least two rings, or if you're passing just one ring, which it should be uh, two wires through that one ring and a drop wire away from the other ring. Now, we have to place and if we are respecting the fracture side, we have to be some 2 to 4 centimeters away from the fracture side in order to maintain the stability of that fracture. Then sometimes we have to respect the soft tissue as well, because we might think that, okay, the pin can go from this side, but what if there's a flap, base of the flap is there on that side. So we cannot put a pin through that flap. So in that case, we have to avoid that flap, and we have to pass a pin from the opposite side, or we have to pass a wire so that the minimum trauma is put to the soft tissues. So what we need is a minimum of 6 cortices in a single fragment, minimum of 6 cortices. So that can be achieved either with 3 wires, or can be achieved with 1 wire or 2 pins, or with 2 wires and 1 pin, whatever we do. But we have to achieve at least minimum of 6 cortices fixation, and also respect the soft tissue as well. Now, what are the things we should use? So as I already said that most of the times we use wires. in an osteoporotic bone, and the wires when we are using near the joints. But if we are going into the diaphyseal area, we in order to save time and in order to save the thermal necrosis of the bone, we try to go with just tapered pins in the diaphyseal area. Then the ring size should be at least you should have 2 finger breadth on all around the leg. The most of the times the whole the swelling is present in the mid part of the leg where the calf is the calf girth of the calf is maximum. So there we try to measure the ring size at that place. The first wire what we put is the transosseous wire which we pass from the head of the fibula. This is the reference wire. We try to put it parallel to the joint as well. You can avoid fibula if you're not distracting or you're not taking osteotomy. But most of the times in these cases of Ilizarov fixation, we do osteotomy. So we try to put the first wire through the head of the fibula into the tibia. So the wire in the first cortex is always drilled, and the wire when we pass to the second cortex is always tapped, because we have to prevent any soft tissue injury when we are passing through the second cortex. Also, we might have to put some additional rings if we have a very small fragment and we are putting a single, if you are able to put just single ring onto the smaller fragment, then you have to augment that ring with another half ring which is put in the foot. Or if we have some associated deformity in the foot, because in long-standing non-unions you might have contracture of the tendo-Achilles, there you might have to augment your distal fixation with the foot frames. Now coming to the level of bones, all the bones or the long bones, be it humerus, be it femur, be it tibia or radius ulna, they are divided into 8 parts by this MUDEF, which is a method of unified designation of external fixation. Now, all these 8 parts, if I tell you the first and the 8th is actually at the end of the bones. So first part is at the head of the fibula, and the eighth division is at the level of the syndesmosis. Now comes rest 2, 3, 4, 5, 6, 7, which is actually if you see the fourth, which is at the middle of these first and 8, and then the rest of the levels are in between these first and fourth and 8. So if we divide the tibia into these 8 parts, and if you see this tibia from the cross section from above, if you see in the figure, this is the left side tibia, and you can divide this whole sector into 12 parts like a clock, and there you can identify which is the safe zone for the tibia. So if I talk about the level 1, which is near the fibular head, the safe zone is if we are passing the wire from 3 to 9 or 9 to 3, or we are passing the wire from 8 to 9 on 8 to 2 and 2 to 8, or we are passing the wire from 4 to 10. So this is a safe zone for the wires in a level 1, that means near the knee joint. And if we see at the level from level 2 to level 6, so we just have two levels, axis in which we can pass the wire, that is 3 to 9 and 4 to 10, where we can pass these wires safely. The rest of the places we can just put a shank pin, but we cannot pass wires in 6 to 12 or any other axis. We can pass the wire from 3 to 9 or 4 to 10. And if we talk about the level 7 and level 8, again we have all these 3 axes which we were using in the level 1 of 3 to 9, 4 to 10 or 2 to 8. So these are the safe zones in which we can pass the wires where if in putting a Ilizarov frame onto the leg. Now, post-operatively, we should give good analgesia to this patient, because these patient, because once they come out of the surgery and they see this frame onto the leg, somehow their acceptability, I have seen most of the time the acceptability, they are ready in the front go, but once they come out of the surgery, I have seen patient complaining to me, how will I manage, So we need to get the counseling of this patient done, because this frame has to go for a long time and it has a lot of problems. I mean, it has problems like pin tract infections, pin loosening, or we have to change wires in between. So patient should be motivated enough to carry on this frame. Otherwise, the result of our surgery might not be as good as we are expecting. Again, we have to put some kind of traction devices like elastic bands or these kinds of support onto the chappal, and we have to cover this frame with the help of some clothes so that patient this is not visible and the patient doesn't feel out of the society when he's walking out. Again, the patient has to be taught all the aseptic techniques of dressing and all use of antiseptic for the dressings as well. Rehabilitation, the patient should always walk with full weight bearing. What I tell to my patient is you walk full weight bearing, because these patients, when they come to us, the bone quality is and this, because since this patient are being suffering from non-unions for a long time, the bone quality is too bad. The bone quality only improves when the patient starts walking full weight bearing. The bone quality dramatically improves. So they should be motivated to do regular knee and ankle exercises. Now coming to my some examples, this is a 40 years male who had a history of road traffic accidents with grade 3B. If you see, we had this was a fracture which has a lot of combination in the proximal part. So, and with this kind of injury, there were two options with us. Either we could have gone for some T-shaped AO kind of fixator, and we could have done a remove all these bony fragments and done a flap on the single setting, and then on the second setting we could have gone for a plate application or a Ilizarov, as the case may be. But here we went ahead with a simple frame of three ring fixation in one ring in the proximal part and two rings in the long segment, and we went ahead and achieved the union in this case. Second case is a 57 years male who had a floating knee injury. This patient was managed somewhere where the primary surgeon had applied a fixator on the tibia and femur. If you see his tibia X-ray, he had a posterior medial plate done in the past. So there was a fracture just below the plate, and the femur fracture was, straightforward. But the fixator what the primary surgeon applied had gone through the rectus muscle. So the moment that we saw this patient, we just first took out the fixator from the femur, and this patient was subjected to distal femur plating for the femur. Once the distal femur plating was done well, when then this patient was subjected, then we thought what to do for the tibia. I had an option to either go for simple plating on the anterior lateral surface, put a long fibula in between. But his diabetic status, he was a diabetic, and his sugar status was not controlled, and his CRP levels not coming down. Every time he used to come to us in the OPD, his CRP levels were up. So I had no option but to think of putting a Ilizarov here. So we went ahead, opened the tibia. We did put a frame in the tibia as we usually do in the proximal segment. We put a one single frame with a drop wire, and in the middle segment we made a middle segment because we did a corticotomy downwards, and we put a wire and a drop wire. We put a ring and a drop wire in the middle segment and a single ring in the distal segment, and we started translating this middle segment up towards the tibia. This is his follow-up X-ray. He is weight bearing. His middle segment has gone to unite onto the proximal part. Unite means it has touched the proximal part and is in the phases of union. And the distal part where I have done an osteotomy, the region it is started consolidating. These are his images. He's walking full weight bearing. This is his video where he's asked to walk full weight bearing on his frame. So to conclude, preoperative planning is a crucial step to ensure success of Ilizarov fixation. Detailed clinical and radiological evaluations are needed for understanding the exact nature of tibial fractures. Every patient is unique, and the preoperative plan should be individualized according to the anatomy, severity of deformity, and desired outcomes. Proper selection and position of Ilizarov frames are very critical to achieve desired corrections. And if we have to do lengthening or a deformity correction, we have to keep in mind that these cases or acute fracture cases might land up into non-unions, and we might have to add some additional rings in between. So we should always keep all these things in mind. It is vital to discuss the process, risk, and expected outcome with the patients and ensure their understanding, because patient motivation is very important in our cases, because if the patient is not motivated, I don't think we can achieve anything in these surgeries. And coordination with the physiotherapists, radiologists, and other specialties can optimize outcome and reduce the risk of complications. Thank you.
Thank you very much, Professor Mohit, for your crisp and lucid presentation and for highlighting all those simple yet quintessential tips and tricks which are actually the key to success. And like you rightly emphasized, the crux of the story is planning, because as it is said, if you fail to plan, then you are planning to fail. So thank you
Yes.
once again for your lovely talk. And if there are any questions for Professor Mohit, sir, we can take them now, or else you can type them in the chat box. Right. So may I now invite our next speaker, Dr. Gaurav, sir, to kindly come forth and present his talk on Ilizarov in proximal tibial fractures. Sir.
Thanks, Rajiv. Is my presentation visible? Is it in full?
Yes, sir, it is.
Thank you. Thank you, Dr. Rajiv. First of all, I don't have any disclosures. So these are important people. I think we all look up to Dr. Ilizarov, and the person sitting, I mean, on the right is my father, Dr. B.K. Sanjay. So I've been taught the entire Ilizarov methodology and how to apply it properly by him. So I'm really grateful to him. This is another excellent surgeon, Dr. Rajiv. We happened to meet in Belgrade recently, and it was a very good moment because coming from a small capital like Dehradun, there were two people who were there to share their experiences at a global platform. So, and I would also like to mention that Dr. Rajat Agrawal, sir, has been, when I was a third year, he was an assistant professor in AIIMS. So we all looked up to him, and it's really nice to see that he has grown to such a good level and that he's the president of ASAMI. So now I would like to just start off with my presentation. So tibia, by virtue of being a superficial bone, when fractured, gives challenging management strategies. Proximal and distal tibial fractures have been known to have high incidence of soft tissue complications with osteosynthesis. This is up to 30%. And there is a paper by some surgeons at AIIMS New Delhi which say that it has, I mean, the incidence is up to 50% also. Soft tissue management is of greater importance rather than aggressive single stage osteosynthesis, which can lead to poor outcomes. So this is one of our cases. He's a 70-year-old male. He fell from a scooty. He was a father-in-law of a patient who we had treated earlier. An above knee slab was applied at his primary place where he lived. So nowadays what happens is a lot of these patients they forward the X-rays on the WhatsApp, and then they want the cost of the treatment. So this was decided, and he was a thin-built person. So you can see his X-ray. This was what he had sort of WhatsApp to us. It's a bicondylar fracture of the proximal tibia. Also, his neck of fibula has been fractured. This is a CT scan, which we saw later on. Three-dimensional CT scan was done because it's an intra-articular injury. And this is what happens when as soon as I remove his slab, which was an above knee slab, which was covered on all sides. So this is one sort of case where I would be very scared to do any form of internal fixation. And for all my proximal tibia fractures, I always span them first. Even if I want to do an osteosynthesis, I would wait for 7 to 10 days because there is always some amount of swelling which can trouble your outcomes. And then we can either think of in definitive Ilizarov or, as I said, an osteosynthesis. So in this case, because we're talking about Ilizarov in proximal tibia fractures, this was one case where we decided to do an Ilizarov. So for all our proximal tibia cases, what we do is we also apply a ring above, that means at the level of the distal femur. This is primarily because we want to give the plateau some extra stabilization and some extra support. And we also like to put in an intra-articular drain, because we feel that after we put an intra-articular drain, the blood which is which or the hematoma that usually communicates intra-articularly with the fracture, and this helps in decreasing the swelling and improving his soft tissues at an earlier stage. So you can see that we have used olive wires. I always use olive wires, and this is the level of fixation which we have been able to achieve. This was on day 1. You can see that his metaphysio-diaphyseal part of the tibia, it is slightly translated, but we managed to go. We always try to go in again after a couple of days or a couple of weeks if we feel that we can improve this fixation or the alignment by any means after our primary X-rays or a recheck CT scan. Then we never shy away from doing that. So, oops. So this is at this is the patient. You can see his blisters, fracture blisters, which we usually call them. They have healed. There's some problem with the video. Finally, excuse me, I'm just trying to go ahead. I'm sorry, I think there was some problem with the videos, and at the end time, it's not. It's just creating some problem. I'm just trying to open it again. Okay, so finally at this external fixator was removed at 4.5 months. Those are just the washers. We try to, when we are especially talking about the proximal tibia, sometimes in spite of using the olive wires to gain some extra compression among the intercondylar fragments, we top them off with some washers, and these washers were finally removed, and you can see that ultimately how the fracture has consolidated is really beautiful. There's another patient. He fell from the scooty. Another above knee plaster was given elsewhere. Came for proxy consultation for pain, and there was a proximal tibia fracture. He was asked to visit immediately. You can see that it's again a comminuted fracture. There's some depressed fragment as well. So this is for this fracture as well. We applied a frame like this. Initially, it was planned that we might need to do some definitive fixation with with some osteosynthesis. You can see that he has extensive blisters which have healed over time. This was his fixation, which we ultimately did. We put in some cantilevered screws as well, and I think it's a reasonable reduction which we have been able to achieve. And finally, for some of these patients, what we try to do is just at 1.5 months, when we partially remove the external fixator, you can see that initially it was an above knee frame, but we've removed the above knee part and also the proximal most ring. We've tried to put it as a half ring. We tactically have to apply wires at the initial point also, or at times we need to cut the ring as well, or you can use some additional small plates to increase the range of motion if we want to use this Ilizarov as a definitive tool for fixation of this proximal tibia fracture. Another 60-year-old male, he had a road traffic accident. He had a puncture wound over his upper 1/3 of the leg. There was a lot of swelling, which can be well appreciated by the X-rays. You can see the soft tissue swelling is quite high. He was a diabetic. He was a gardener by occupation, and he was not willing for the risk of an infected osteosynthesis. To that, what I want to say is that sometimes when you offer them, you say that right now your soft tissues are not very well. Would you like to go for a second surgery? But as you say that even a puncture wound, they can land up into a lot of acute infection, which can be disastrous for especially those patients in whom money is always a problem. So he also decided to go for Ilizarov fixation as a definitive modality. So this was his immediate post-op. This is his follow-up at 6 months. You can see he's walking very comfortably. This is his follow-up at 7.5 months. The fracture has consolidated really well. Another 45-year-old female. She's an Ayurvedic assistant professor at one of Ayurvedic medical college nearby. Has a lot of high pain sensitivity. This was her fracture. You can see that it is a very high tibial plateau fracture, and that means what I want to say is that even if you want to opt for an internal fixation with 2 plates, the plates will basically just act as buttressing. You can't really place the plate very high in such a fracture. This is her CT scan. So we managed to do this. This was at day 1. We put in some canceller screws, one from the lateral to medial side, one from medial to lateral side, and did a sort of supplemented with an Ilizarov external fixator. You can see that an above knee frame has been applied for this patient as well. We removed the above knee component within 2 weeks, and then asked her to start a range of motion. This is after removing her above knee component. You can see that the fracture has started to consolidate. The frame was removed at 1.5 months. The reason being that the patient was not very compliant. She was always complaining of pain, and although she's a doctor from an allied field as well, so that prompted her and prompted us as well to remove the frame. We gave her an above knee cast, PTB cast for a couple of weeks, and asked her to start a range of motion. That lady, she had persistent problems with regaining her range of motion. This is another 63-year-old male. He presented to me after a year. His primary treatment was done at Meerut. Implant removal was done elsewhere after 3 months. Discharge was persistent since his first open reduction internal fixation, which was done. This is how he presented to us. This was his first X-ray, which I found from his records. And then you can see that this is a bicondylar fracture. He also has a neck fibula fracture. This was immediately fixed after injury elsewhere. You can see that this is an inadequate fixation. The fracture has been fixed in varus. Lateral plate never works also just for a bicondylar fracture, even though the plate may be fixed angle locking plate. So you can clearly see that this patient needed, if in case he needed a osteosynthesis, his posterior medial condyle needed to be fixed and supplemented with a plate, which was not done. Probably the instability and part of the of treating the fracture led to him getting an infection as well. Could be a possibility. So this was after his fixator was removed elsewhere, and you can see that the fracture is going in varus. This is how we presented to us. You can see that there is shortening and the fracture is in varus. This was his his wound when we debrided it. And this is his gastrocnemius rotation plasty, which was done for this patient. After that, we put in a split skin graft to cover his wound. And you can see that, we've supplemented it with an Ilizarov. The reason being that we wanted to correct his deformity as well. He just came a week back. You can see how beautifully his fracture has consolidated, and his alignment is really good. This is one case which was very challenging to us. It was an open fracture of both bone leg. He was advised amputation elsewhere. So you can see his level of injury, and also how high velocity trauma he must have sustained. It is almost looking like a blast injury within his tibia. At the primary hospital, all these loose pieces, they were removed, and the patient came to us with the X-ray on the right side. This was his level of soft tissue injury. The photograph on the left side is his calf. You can see that he has a huge soft tissue defect. There's no skin, and anteriorly you can see that the bone was totally exposed. So initially we tried to manage soft tissue. We did a split skin graft and applied it on the posterior aspect. You can see that there was a huge graft which had to be applied. Initially, his fracture was maintained on this sort of a uniplanar fixator, in which we tried to give as much as stability as we could. You can see the visible amount of shortening he has. And this fixator was initially used because in order to do dressings for such a big soft tissue injury, sometimes the Ilizarov can be a little bit of a problem while trying to dress these wounds, because we try to use VAC for a lot of our skin graftings and for wound management. And then these pin sites, they often lead to air leakage when we apply Ilizarov, or if we apply an Ilizarov. So you can see this was his initial X-ray. His normal tibia is 37.5 centimeters. His tibia, which we had to operate or get back into position, is around 29.5 centimeters, almost 8 centimeters shortening. This was the frame which we applied. We've used some carbon rings which help us in assessing our reduction and also consolidation which occurs over time. We have also applied a foot frame for him, which I feel is always essential, because a lot of these patients, as Dr. Mohit has rightly pointed out, that we tell them to walk, but they don't want to walk. When they come again after even 4 or 6 weeks, they have a very bad looking equinus deformity. So we did a bifocal corticotomy for this gentleman. You can see on the X-ray on the right. This was done to save time. The frame which we applied has you can see on the left side. We tried to cover his wound with secondary suturing, and tried you can see that the margins of the skin, they were getting inverted. So we tried some indigenous method, and you can see that the nylon is hanging on to some of our rings. This was to redirect the skin margins. And finally, you can see that this has consolidated very well. The patient took almost, I think, 1 year, 8 months to finally be off frame. This was his X-ray, you can see on the left, which was his X-ray which we had to manage. And this was his final reconstruction, which we could give to him. I don't know if this video I can play it. This gentleman, he's working as a driver in Jolly Grant Airport, and he's really happy with his results. So all the fractures within these cases which I have shown, they healed. Mean time to union is usually around 4.5 months. In closed injuries, most patients achieved a range of motion around 5 to 100 degrees. Pin site infection occurred in a few of these patients, but they could be managed with simple dressings. Ideal cases to do Ilizarov. Well, I would say open cases are probably some of the cases where I would always like to do an Ilizarov. When there are fracture blisters, especially in bicondylar tibia fractures, proximal tibia fractures, I'm always very scared to do an internal fixation, especially when they have blisters. And even if you wait for 7 to 10 days, often you can land up in a disastrous complication of an infected osteosynthesis. So what are the challenges and tips? Well, patient compliance. Females are more intolerant to Ilizarov external fixator. The weight of the frame is sometimes an issue for them. Pin site infection can be prevented by adhering to the principles of Ilizarov, which has been rightly very well in detail been explained by Rajat sir. Multiple fragments in tibial plateau fractures can be pre-addressed with a 3D CT, which can allow a better pre-operative planning. So this has been explained well by Dr. Mohit Dhingra. Olive wires and CCS screws help in managing these injuries. And I always feel that it is the soft tissue thing which really dictates how how we move ahead. Carbon rings at the site of comminution or near to the fracture site help in better radiographic post-op assessment. Post-op CT can be done to check the fragment specific wires. By that I mean that if we know that there is a specific fragment which we can reduce in a better way, then the CT is always helpful, be it pre-op or post-op, even if you want to revise. And my father has always given one tip, which is that you should always revisit these fixators or these patients on fixators in the OT for improvement in fixation if you cannot do it on day one. As Mohit sir has rightly pointed out, that these Ilizarov surgeries, even for the people who are doing these very frequently, they can run into 3 to 4 hours also sometimes when you don't have trained people along with you. And that external fixator removal, prior to removal, I would always suggest that you do manipulation under anesthesia to get a head-on start with the range of motion. A lot of times, you see that these patients they're not moving their knees, especially in proximal tibia fractures. They will always give a reason that the ring behind. If we use a full ring or 2 half rings at the proximal segment, they will say that doctor saab, piche, I can't move my knee. The frame always touches the back of my thigh. But again, then as I said that because if we talk about definitive fixation, then this is one thing which we can do. Ilizarov is a safe and a magical tool for tibia fractures, especially with comorbidities, with poor skin condition and open injuries. It can be used as a definitive form of fixation with the least chance of deep infection and soft tissue problems associated with internal fixation, which is as high as 30 to 65%. It is almost a bloodless surgery. Early weight bearing is possible if we can really counsel these patients. One of the ways which I use is that, I try to show them some post-op videos of our patients who are walking well. If there's an old man, just like which I've shown in one of my slides, and if there's a young guy who comes to us, it's like look at this guy, he's so old, he can walk, why can't you walk? Then probably, this gives them some sort of boost that, yes, it is possible. Sometimes they feel that, this fixator is very they feel that, these wires cannot hold their bones together. But I think this is a very rock solid way of treating tibia fractures. Thank you very much. Thank you, Dr. Rajiv.
Thank you, Dr. Gaurav sir, for sharing your insight and your practical tips and tricks, which of course comes from years of experience. Your center has extensive experience with the apparatus. And I'd also like to say that I was absolutely mesmerized by the picture in which you have done your flap by yourself. So I think food for thought for us orthopedic surgeons, little bit of plastic procedure, some training in basic plastic work may help us in the long run. Thank you so much.
I won't say may, Dr. Rajiv, but during our post graduation, we are always looking for when to get the first plate to fix, when to get the first fixator, when to get our first nail. But I think our postgraduate tenure is too small. It should actually be for 6 years. We are usually pushed off into training at a very naive stage, when we can make a lot of mistakes. As you can see in your practice or in our practice, even at this age, there are so many nuances which we have to learn from experience, and experience comes from getting a good training. And I feel that for especially trauma surgeons, as you have rightly pointed out, basic plastic surgery, especially split skin grafting for tibia, we need to know how to do rotation plasty of our gastrocnemius. Plastic surgery is really interesting, and when you can do it all by yourself, the beauty is that you don't have to really depend on other people, especially when the resources are very scarce. And I think plastic surgery, especially it does help us as trauma surgeons a lot.
Yeah, rightly pointed out. Thank you so much for your informative talk. So
Thank
if
you,
there are
sir.
any questions for Dr. Gaurav, we can take them now, else you can leave them in the chat box.
Gaurav, I would like to congratulate you. You're doing such a wonderful work in Dehradun, because I was hardly knowing any many surgeons who are doing Ilizarov there, and it's pretty nice that you are bearing the flag of Ilizarov surgeries there, and keep it up, and best
Thank
of
you,
luck.
sir. Thank you, Rajat sir.
Right. Could you please unshare? Thank you. And finally, we come to the last bit of this series. So from all parts of the tibia, we now come to the distal tibia. And I'll just share two cases. We go straight to the case. This is a case of a 28-year-old male soldier who had a road traffic accident in October 22. And this patient was airlifted to us when we were in Pune. And he had sustained a grade 3B open fracture of the tibia fibula. I remember he had reached somewhere around midnight, and we had taken him up for surgery immediately after in the wee hours of the night. And the procedure done was a standard debridement and an external fixator application. So 3 weeks later, we took him up for a redebridement and a conversion to an Ilizarov frame was done. Now, please notice the way these counter-opposed olive wires have been applied. If you remember, if you go back to Dr. Rajat sir's talk, he spoke about the reduction wires, and this is an example of that. When the wire is inserted in the opposite fragments and tensioned on the other side so as to achieve interfragmentary compression. So this was an example of this particular phenomenon. Also notice how the ring has been aligned in a way so that it does not obscure your joint line. So this is something to be kept in mind. This patient also had a contralateral calcaneal fracture, and surprisingly, he was full weight bearing on the fixator side and non-weight bearing on the other side, which denotes the stability of the construct. So as we see in his follow-up X-rays, union was in progress and no more interventions were required. That's his final clinical picture before and after frame removal. We always make it a point to brace our patients for a period of maybe 6 to 12 weeks after removal of the frame. And this is X-ray at 6 months and on the right at 8 months post-operatively. This is his functional outcome. He's a soldier and he's back on duty without any restrictions. This next case is that of another soldier. He's a 48-year-old junior commissioned officer. He sustained an accident while on duty. This was somewhere in the northeast, and he had sustained a grade 3 open fracture of the ankle, which was managed initially at a civil hospital. Some sort of external fixation with some K wires was done, and thereafter he was transferred to our center about 2 months later in a bad condition. He had discharging pins and an unhealthy wound. So this was the X-ray on arrival. You can see that all the pins are bending and some of the pins are loose and in the joint. So what we did was we took off the fixator, gave him a cooling period, put him on some antibiotics, did some local wound care and waited for everything to cool down, which took about 2 weeks. Following that, we did an NCCT of the ankle, and this is the picture of the bone. So as we can see, it's absolutely comminuted. Lots of fragments there. Everything is maluniting. And this is his clinical picture. The ankle was in valgus and bit of recurvatum. So initially the plan was to get this comminuted mass to sort of consolidate by applying the principle of ligamentotaxis using an Ilizarov frame. So we applied one ring over the distal tibia. And if you notice, this ring is a radiolucent ring. It's a carbon ring. And that helps us to visualize our joint line better. Of course, one has to span the ankle and get some fixation in the foot. And the distal tibia ring was mounted on hinges. We tried to perform a correction using the hinges, but unfortunately, the fracture had already begun to consolidate. Please note that this was performed closed and there was no open bone grafting or any such thing, because the aim of the procedure was just to get the bone to consolidate so that we could do some correction at a later stage. Later, once the bone had consolidated on the follow-up X-rays, we took off the foot frame and began to mobilize the ankle. However, once the frame was removed, we noticed he still had some residual valgus at the ankle. So we planned for a corrective osteotomy. By now, of course, his infection had subsided. The skin looked good. So we decided to do this using internal fixation. So that's his ankle, and that's the amount of valgus that he had. So there's the site of the proposed site of the osteotomy. This was done using a supramalleolar dome osteotomy technique, like so. It's done through an anterior approach to the ankle. A Steinman pin marks the cora, and the dome is created by using a cube or a post like so. And finally, the rotation is done. A fibula osteotomy is also done, and it was fixed with a medial tibial plate and a fibula plate like so. Some supplemental bone grafting was done from the bone harvested from the upper tibia, and an anterior buttress plate was added to give some extra stability. Since the bone in this region was very, very osteoporotic, and we wanted to have a good, stable internal fixation, we went for a bicolumnar fixation like so. And this went on to unite. On the left is his immediate post-op X-ray, and on the right is a 2-year follow-up X-ray of the same patient, showing good consolidation and good alignment of the ankle. That's his clinical picture. And surprisingly, he had a good range of motion at the ankle joint. And that's him walking painlessly and with good function. So a few tips and tricks. We know that the distal tibia is a watershed zone between the three vascular territories, the anterior tibial, posterior tibial, and peroneal arteries. So our incisions should be planned accordingly so as to not violate the zones. Counter-opposed olives can be used for reduction of the displaced fragments, like pointed out. A radiolucent ring is beneficial for better visibility in and around the joint. The frame should definitely extend to the foot in case you have a small distal fragment. Of course, that can be removed at a later date to regain your ankle range of motion. And the advantage of Ilizarov in distal tibia is that it is minimally invasive, respects the soft tissues, and there are no large open incisions. So thank you very much. I'm done with my presentation. If there are any questions or comments, we can take them now.
So I think Rajiv, it's a perfect example of very bad, potentially very bad cases done in a very simplistic manner. To the viewers, it will be looking, it's a very simple surgery and done beautifully, but the fractures, it would have been gone into very bad conditions. So I think you managed it very well, and the final outcome was excellent, that with good union and with good range of motion. And that the first case was like, with a very simple technique and surgery, you were able to achieve the final outcome in a very simple manner. In other hands, in other techniques, it would have gone to some very bad results. So I think a very good example for the beginners and the young surgeons to tackle many fractures in this manner and getting a beautiful outcome. Thank you.
Thank you, sir. I thank all our speakers for devoting their valuable time for the purpose of education. And before we conclude, I'd request Dr. Rajat sir to give his final concluding remarks before we close this session. Over to you, sir.
Yeah, so to all the viewers and people who will be watching the videos later, so our main aim is to, like, we are orthopedic surgeons, so we never say that you do only Ilizarov. It's like personally, in my experience, I prefer plating over Ilizarov. It's not like I do Ilizarov, so I will just be doing Ilizarov only. Like my professor, Dr. Harrison in US used to say that there will be a time when I don't just, I will avoid using fixators, and internal fixation is better. But if you are knowing both the techniques, so there are many cases when you will prefer that Ilizarov may give you a better outcome in a simplistic way. So my only appeal is you learn both the techniques, because then only you can be unbiased. If you know how to do plating or a nailing and you don't know how to do Ilizarov, so definitely you will always prefer a plating or nailing, and sometimes it may ends up in bad results. So our appeal is you learn both the techniques. When you are learning both, then you will be able to decide in a much efficient manner in which case which is better, and your outcomes in terms of surgeries and results will be much better in your practice. So thank you all the viewers for sparing your valuable time and listening to us. And I hope that these videos and the webinars will be helpful to you in your long term. Thanks a lot and good night.
Thank you.
Thank you, Thank you, sir. Thank you, Mohit, sir. Thank you, Gaurav, sir, for your time. And we look forward to meeting you all. Thank you, Dr. Shamsul, sir. And we look forward to meeting you all very soon next month at ASAMI Con. Good night and take care.
Thank
you, everyone. Thank you. Good night.
Good night.
Rishi, can we stop?
Okay, sir. Okay.
Yeah, thanks, Rajiv. Please end.